What if the blood pressure number you're trying to reach is actually putting you at risk? There's one question that can change your target completely, and I'll show you what it is. Here's something concrete right away. In August of 2025, the American Heart Association and the American College of Cardiology, along with 11 other medical societies, published new blood pressure guidelines. It's the first full update in 8 years. If you haven't heard about it yet, that's not surprising. It's brand new. Here's the twist. You'd think getting older means the rules loosen, that a slightly higher number becomes fine, expected, nothing to worry about. Actually, it went the other way. For most adults, the guideline got stricter, not looser. So here's the real question. Does most adults include you? That's what we're going to find out. Stick around. There's a piece of evidence coming up that changes how you think about this number, and a twist after that about why chasing it too fast can backfire for some people. This isn't a video about memorizing a new number. It's about understanding the logic doctors now use to set your number. Once you understand that logic, you can take part in the conversation instead of just nodding along at your next appointment. Let's start with why your body handles this differently now than it did at 40. Picture a garden hose left out in the sun for 20 years. It's lost its give. Your blood vessels go through something similar. The artery walls stiffen with age, so your heart has to push harder to move blood through them. That extra push often shows up as a higher number on the cuff. There's a second, quieter change happening too. Your kidneys, which play a big role in regulating fluid and salt balance, don't process sodium quite the way they did decades ago. That's part of why a diet that never used to affect your blood pressure much can start to matter more now. None of this is a flaw in your body. It's just a different set of mechanics than the ones you grew up managing. Which is exactly why a number that worked at 40 doesn't automatically carry over to 70. Hold on to this for later, because it flips an assumption near the end of this video. A lot of people go through all of this and feel completely normal the whole time, no warning signs. We'll come back to why that matters more than almost anything else here. Many people past 60 are also managing diabetes, or kidney changes, or a heart medication already doing work in the background. Every one of those factors changes not just your blood pressure, but how your body reacts when someone tries to lower it. Some people feel fine through it. Some stand up and the room tilts for a second. That second group matters in a few minutes. Remember that detail. Now, the belief I actually want to challenge. You'd think that if lower blood pressure is better for your heart, the goal for every older adult should simply be get it as low as safely possible. That sounds reasonable. It's also not what the guideline says, and understanding why is the key to this whole video. So what changed specifically? The new guideline sets a general treatment target of under 130/80 for most adults. That's the population level direction, the number researchers and clinicians are working from as a starting point, not a prescription handed to every individual watching this. And it comes with real fine print. The guideline calls for individualized targets specifically for older adults who are frail, medically complex, or facing a more limited life expectancy, built around a balance of benefit and safety, rather than one number applied to everyone. That fine print does more work than the headline number does. Here's the study detail behind it because it explains everything that follows. Across a large body of research, meaningful drops in the top number, the systolic pressure, have tracked with lower rates of heart disease, stroke, and heart failure. That's real, and it's a big part of why the target tightened. But a lot of that research comes from populations that were, on average, healthier and less frail than some of the people watching this right now. The benefit is real. It just doesn't apply identically to every person. And that's the detail almost nobody mentions when they talk about this guideline. It's also why the guideline pairs that target with a broader risk calculator, weighing your blood pressure alongside your cholesterol and other conditions, rather than treating one reading as the whole story. So which side of that are you on? Picture two people side-by-side composite examples, not real patients, but familiar to anyone who spent time in a cardiology waiting room. Linda is 68, walks most mornings, feels steady, takes one pill for cholesterol. Her reading today, 1:38/85. She's mentioned to friends more than once that she assumed that number was simply fine for her age. Nobody had ever told her otherwise. Robert is 82, 4 medications for heart and kidney issues, 2 dizzy spells in the last few months getting out of bed, one bad enough that he grabbed the dresser to steady himself. His reading today, 136/82. Look at those numbers again, 2 points apart on top. If blood pressure care were only about the number on the screen, Linda and Robert would get the same plan. They don't. Linda's doctor looks at her overall picture and says working gradually toward under 130/80 fits the standard lower risk profile the guideline was built around. They agree to revisit her diet and activity level first and check back in a few months before considering anything more. Robert's doctor takes a noticeably more cautious route because pushing his numbers down quickly could raise his risk of a dizzy spell or a fall, which, at 82 can be more dangerous than the blood pressure reading itself. His plan moves in smaller steps, with closer monitoring along the way, and a conversation about whether any of his existing 4 medications might be contributing to those dizzy spells in the first place. Same range, opposite pace. Here's the tension underneath this entire guideline, worth holding on to for the rest of this video. Lowering blood pressure can meaningfully reduce your risk of heart disease and stroke, and lowering it too fast in the wrong person can create a different kind of risk entirely. Both facts are true at once. The guideline exists to resolve that tension for one person at a time, not for people over 60 as a category. 2 more signals worth knowing before we get to which one you're closer to, because most people misfile them. If you've ever stood up and felt the room swim for a second, you probably blamed it on standing too fast. Sometimes that's right. But in someone on blood pressure medication, it can also mean the pressure dropped lower than intended when you changed position. Robert's exact scenario. That's a mention it soon symptom, not a shrug it off one. The second is the gap between your office reading and your home reading. The two are often meaningfully different, which is exactly why the updated guideline puts real weight on home monitoring as data your doctor is expected to use, not just a backup check. And this is where that earlier detail comes back. Remember when I said some people go through all of this feeling completely normal? Here's why that matters. High blood pressure is frequently silent. No headache, no dizziness, nothing that tips you off. You can feel entirely fine and still have a reading that needs attention, which means how you feel isn't a reliable way to know where you stand. The reading is. One more category isn't a bring it up next time situation. A reading of 180 over 120 or higher, combined with chest pain, a sudden severe headache, or a change in your vision, needs medical attention immediately. That combination can mean organ damage happening in real time. That same number alone, without those symptoms, is worth addressing calmly and soon instead. Don't confuse the two. Treating either situation like the other can cause real harm. Now, the moment this video has been building to. Run through these 5 questions, because each one reveals a different piece of what should shape your conversation with your doctor. Think of each as its own short chapter. Question 1, your profile. Are you generally active, with no recent falls or fainting? This tells you whether you fit the profile. The standard target was built for closer to Linda than to Robert. If yes, working toward under 130 over 80 at a gradual pace agreed on with your doctor is the direction the guideline points for someone like you. Question 2, interactions. Are you on several medications, especially for your heart or blood pressure? This isn't about whether you should be cautious, it's about whether your medications interact in ways that change how your body responds to a lower number. That's a specific, separate conversation from your target itself. How these drugs work together and whether any of them need adjusting before your target does. 2 people on the exact same target can need very different paths to get there, depending on what's already in their medicine cabinet. Question 3, pace. Have you had a fall, a fainting spell, or a low pressure episode recently? This one is about pace, not destination. It doesn't necessarily change what number you're working toward, it changes how quickly and how closely that change should be monitored. Robert's situation exactly. His target isn't necessarily different from Linda's. His route to get there is. Question 4, risk. Do you have diabetes or kidney disease? This one raises the stakes rather than the caution. The evidence behind the guideline shows a benefit for cardiovascular outcomes broadly, and specifically for slowing kidney disease progression in people with diabetes. It's the one question that can make your case for the lower target stronger, not weaker, worth naming clearly at your next visit rather than assuming your doctor has already factored it. In question 5, safety. Are you managing several conditions at once, or noticeably more frail than a few years ago? This is about weighing the number against your quality of life. If this is you, your day-to-day safety and how you actually feel carry just as much weight in the decision as the reading does. Not a lower standard of care, the guideline explicitly telling your doctor to treat the whole person, not the number on the screen. 5 questions, 5 different pieces of information: profile, interactions, pace, urgency, and quality of life. None of them hands you a personal prescription. What they do is tell you exactly which factors should be shaping your conversation with your doctor and what to actually ask about when you get there. Here's what to do with that this week. Find your last reading and see where it sits against under 130 over 80. If you don't have a home monitor, this is a good time to get one. A basic upper arm cuff, used a few times a week, gives your doctor a more complete picture than a single office reading once a year. And walk in with this exact sentence: based on my health and my current medications, What is my personal blood pressure target and why? That question gets a specific answer. A vague one doesn't. Alongside that conversation, the everyday habits worth building are the ones you've probably heard before, and they still hold up. Regular movement, even something as modest as a daily walk. Being mindful of sodium where you reasonably can, limiting alcohol, and managing stress where it's within your control. None of that needs to be extreme to matter. Small, steady changes tend to move these numbers more reliably than dramatic short-term ones. And it's worth knowing your own signal for reaching out sooner rather than later. New dizziness, fainting, or numbers that keep sitting above whatever target you and your doctor agreed on are all reasons to call, not wait. A few beliefs worth flipping before we close. You'd think only the doctor's office reading counts. It doesn't. Home readings are now treated as real data, not a footnote. You'd think lower is always better. Full stop. It isn't. As Robert's situation showed, moving too fast can create new problems for the wrong person. The goal was never the lowest possible number. It's the right number, reached at the right pace, decided with your doctor, not chased on your own. And you'd think a single high reading means something is seriously wrong. Usually, it doesn't. One reading can bounce around for all sorts of ordinary reasons. From a rushed walk to the parking lot to a stressful phone call beforehand, which is part of why doctors care so much about a pattern of readings over time, rather than any one moment on the cuff. So back to where we started. What is your ideal blood pressure? You don't get to answer that alone, and neither does this video. What you have now is the exact factors that shape it, and the exact question that gets your doctor to answer it, specifically for you instead of generally. But here's a problem nobody warns you about. You can walk in with the right question and still walk out with a number that's wrong, not because your doctor got it wrong, but because of how the reading itself was taken. Arm position, timing, even talking during the measurement can throw off a home reading enough to change the whole conversation. So here's the real question for next time. Are you even measuring this correctly? If this changed how you think about your own number, subscribe to Prime Health Insights so you catch it. And if someone in your life has been told to keep an eye on their blood pressure without ever being told what that means, send this to them.